Welcome dear students. Today the topic that we are going to discuss is the muscular dystrophies. These are the progressive muscle damages. These start from the childhood and progress to the adulthood. And these muscular dystrophies are X-linked muscular dystrophies with dystrophin mutation. Dystrophin is the protein. About that we will further discuss in the subsequent part of the lecture. Duchenne and Becker's dystrophy. These Duchenne and Becker dystrophies are also called the dystrophinopathies. These dystrophinopathies, because there is a deficiency of the dystrophin protein, and where somewhere there is a deficient production of the dystrophinopathies, and somewhere there is normal production also of the dystrophin, and there is also abnormal production of the dystrophin protein. Dystrophinopathies. The most common early onset form of the muscular dystrophies is the Duchenne's muscular dystrophy. In the male, the death rate is 1 in the 3,500 patient. And this is a total, you can see this is a total dystrophin absence. There's a total absence of the dystrophin protein. Now the first is the most early onset form, and the later onset form that starts in the later life, in to say in the childhood, late in the childhood, in the adolescence, or in the adult. The Becker's muscular dystrophy. This is synthesis also present. Synthesis of dystrophin is also present, but is a truncated versions of the dystrophin protein. Truncated version means there are the abnormal production of dystrophin protein, and unfavorable inactivation of X inactivation may lead to the and that's why this is less severe in the female due to the unfavorable X inactivation. Now, what is the X inactivation? X inactivation occurs in the females, and male X gene encodes the 50 chromosomes when they fuse, when there is a fertilization, or when the embryo is being developed in the uterus. And there are the male genes that are gained from the parental root, and there are the female genes also present, chromosomes, X chromosomes. And if there is a male X chromosome is involved in the fertilization, and the female X chromosome, the baby male is going to be developed as an embryo, and the female encodes the thousands of the proteins, and male encodes only 50 proteins. To remove this difference, X inactivation occurs. One of the chromosome number X is inactivated to balance this protein production. And how this occurs? There is a gene, XIS gene. This is called XIS gene, and this XIS gene produces the long non-encoding RNA, and this makes the protein. This is a special protein that makes the covering around the active chromosome, and this active X chromosome becomes a inactive chromosome, and this is actually a Bohr body that is seen in the female only, and it runs from the mothers to daughters. It runs from, once the inactivation of the chromosome X inactivation has occurred, it runs from the mother to the daughter, generation to generation. And every time when the daughter will get fertilized with another male, and this imbalance of the energy protein production will also activate the X inactivation in the daughter also. What is the pathogenesis of the muscular dystrophies? There is a dystrophin gene there is a dystrophin gene on the X chromosome, you can see. And this dystrophin gene, in this dystrophin gene, frame shift mutation occurs. What is the frame shift mutation? Mean to say, when there is there are the codons of three nucleotides, one nucleotide, two, one, two, and three nucleotides. Okay, and there is the codon of nucleotides on the DNA. And when there is addition, you can see this is a deletion of the chromosome, deletion of the nucleotides. And when there is a deletion, mean to say, I also make the another nucleotide sequence 1 2 3. And for example, here is the mutation, here is the deletion mutation. What happens? And these two proteins, these two nucleotides deleted from the segment, DNA sequence. And 1 2 3, and these are removed. 4 5 6 7. 5 6 7. You can see these there is an absence X Y, or you can give any name. There is absence of these mutations, right? If I mean to say, there is intact, intact of these nucleotides are intact, and these nucleotides are deleted from the DNA sequence, and these nucleotides has moves toward the intact nucleotides in this direction. These nucleotides are shifted. These nucleotides are shifted in this direction. This is called the frame shift mutation. There can also be the addition. This addition type of frame shift mutation. There can also be the deletion type of frame shift mutation. Now what happens? This dystrophin gene is present on the X chromosome, and this encodes the dystrophin protein, dystrophin glycoprotein complex. This is formed, and this is the largest protein. This is one of the largest protein in the human gene, and it contains the 79 exons and 2.3 million base pairs. This is the largest protein in the human genome. And what are the exons? Actually there are the introns are also there. Are the exons in the DNA strand when they before the slicing occurs. What is the slicing it, for example, this is the exon, so this is the intron, and this is the exon. What happens? Slicing is the process when introns are removed and exons makes the coding strand of DNA. Exons makes the coding strand. These introns are non-coding part of the DNA, and these are removed by the lysosomes. By the lysosome, these lysosomes cut at this end and remove, also cut at this end and also cut at this end, and remove the introns from the DNA strand. These are the non-encoding and remain in the nucleus, and these exons make the coding strand of DNA. Okay, and that's why these are the exons, and this protein contains the 79 exons. You can see this is the basement membrane, where there now we are going to exactly see where there is a presence of the this dystrophin protein in the cell membrane. You can see this is the dystrophin alpha arm, and this is the beta arm. This is transmembrane, and this is the sarcoglycans. This is the sarcoglycan protein. and this it has alpha, beta, gamma, and delta. mm, Alpha, beta, gamma, and delta arms. This is the plasma membrane. This is embedded protein. This is cytoskeleton of the myofibril. We're discussing about the muscles. We are discussing at the myofibril level. Okay, and this dystrophin glycoprotein complex. This dystrophin is the main component of the dystrophin glycoprotein complex, and it provides the mechanical support stability to the myofibrils and muscle membranes. Okay, and you can see this is the glycoprotein. This is the dystrophin protein, and it's a transmembrane protein. The function of the dystrophin, as we have discussed, provides the mechanical stability and the myofibril to the myofibrils and cells. ये सेल को support देती है, and you can see here this is the actin filament. This is the actin filament, and this is dystrophin protein that in the cytoplasm joined to the one end, or joined to the its one end is joined to the actin filament, and second end is joined to this protein. This protein, what is this protein? This is the dystroglycan protein, alpha subunit and beta subunit, and you can afford to forget this protein, these cytoskeleton proteins, and remember only this one, because we are going to talk about this one, nitric oxide synthesis. Let's come to this. This is the N terminal of the dystrophin protein, and this is the carboxylic terminus of the dystrophin protein, and this is this protein is embedded in this like this, and this is the alpha component, and this is the beta component of the dystroglycan protein, and this component, alpha component, is attached to the laminin protein. Laminin 2 protein, you can look there. This is a laminin 2 protein. This is extracytoplasmic protein, extra cellular matrix, and this is the basal lamina. This is the basal lamina, basement membrane. At the dystoglycan, there is a junction between the basal lamina and the transmembrane protein, and this complex give the stability to the cell membrane, and retains the integrity of the extracellular matrix and the intracellular matrix. And this cytoplasmic actin in the myofibrils is involved in the mechanism of the contraction, and this carboxylic terminus of the dystrophin protein is involved in the formation of the nitric oxide from the nitric oxide synthesis, and nitric oxide is formed from the L-arginine amino acid. And when there are the defects in the dystrophin protein, what happens? Cell tears, mean to say there is no protein, and or there are truncated proteins here, and there occurs a cell defect. And after when the cell defects occurs, or cell tear, when there is a cell tear, influx of the calcium occurs, and this calcium accumulates in the cell. This is the cell, and this calcium accumulates in the cells, and it may lead to the myofiber degeneration, and phenotypical changes also occur in the cells, and we will talk about these phenotypical changes that occur in the patient. Duchenne and Becker's dystrophy. Almost similar. Both are similar, almost, but there are some differences, and let's talk about the familiarities between these two dystrophies. Muscular damage beyond the repair. Okay, both segment में इन बोथ में क्या होता है, इन दोनों डशीन और बेकर्स डिस्ट्रॉफी में सेगमेंटल मायोफिब्रल डिजेनरेशन होती है, उसमें रिजेनरेशन भी मौजूद होती है. ठीक है, प्लस एट्रोफिक मायोफाइबर्स वहाँ पे मौजूद होते हैं, एट्रोफिक मायोफाइबर्स वहाँ पे मौजूद होते हैं। ऑन बायोप्सिस में ये सारा ये दोनों जो चेंजेस हैं वो सेगमेंटेड मायोफाइबर्स रीजनरेशंस होती है उसमें, और एट्रोफिक मायोफाइबर्स ये बायोप्सिस में शो होते हैं यंग बॉयज़ की बायोप्सी में। अच्छा, जो फेसिकुलर जो आर्किटेक्चर होता है, ठीक है, वो क्या होता है, प्रिजर्व्ड होता है। फेसिकुलर आर्किटेक्चर जो है प्रिजर्व्ड होता है, ठीक है। उसमें नो इन्फ्लेमेशन होती है, ठीक है, नो इन्फ्लेमेशन, और इसमें मायोफेगोसाइटोसिस मौजूद होती है। मायोफेगोसाइटोसिस मीन टू से मायोसाइट्स आर बीइंग ईटन बाय द मैक्रोफेजेस। And as the disease progresses, what happens, the muscle tissues in the muscle tissues, collagen and fat increases, and this increase in the fat and collagen may lead to fatty replacement and the infiltration or fatty infiltration. This you have to remember this point, okay. And small changes, gross changes move toward from the small atrophic fibers, स्मॉल फाइबर्स होते हैं, मसल फाइबर्स स्मॉल से लार्ज होते हैं, हाइपरट्रॉफिक होते हैं, ठीक है। उसमें क्लिनिकल फीचर्स देख लेंगे कि बॉयज़ विद द डिशीन मस्कुलर डिस्ट्रॉफी आर नॉर्मल एट बर्थ, दे आर नॉर्मल एट बर्थ, walking delayed in these boys, and first weakness appears in the pelvic girdle. First, for example, this is a patient, and this is the shoulder girdle, and this is the pelvic girdle, and in this area, pelvic girdle, the weakness appears. First, the weakness appears in the pelvic girdle, and this weakness extends superiorly to the shoulder girdles. This weakness appears in this direction, upper direction, and in the lower legs. Here in the lower legs is hypertrophy. Why this is there is hypertrophy? We will talk about it with the graphical representation. Enlargement of the lower leg muscles. This is pseudo hypertrophy, and one thing I want to tell you about the pseudo hypertrophy, there is fatty infiltration here. Here there is a fatty infiltration. Fatty infiltration. Mean age of the wheelchair, mean to say the patient is settled down on the wheelchair due to the weakness in the 9.5 years of age. Patient develops joint contraction, scoliosis, and lordosis also occurs. Respiratory discomfort, sleep hypoventilation, heart failure, heart and brain also affected, because dystrophin is also present in the heart and brain cells. Dystrophin deficiency, if this is in the heart, and this dystrophin deficiency may lead to the dilated cardiomyopathies. And arrhythmia also occurs, particularly in the older patient. These both changes particularly occurs in the older patients. In the brain, cognitive impairment occurs. Sometimes it may lead to the frank mental retardation. And 25 to 30 year of age is the death age of this the Duchenne muscular dystrophy. Plus respiratory failure, respiratory insufficiency also occurs, pulmonary infections occur, and the heart failure. These occur from the 25 to 30 year of age. Let's talk about the histopathology of this disease at the successive stages, and you can see this is the These are the two brothers A and B. Okay, these are the two brothers. Uh, this is the picture. All this picture is of the two brothers. This A is the one brother and C is the second brothers at the adult stage. This is at the infancy stage. This is a 3-year-old boy, and in this picture, in this all this picture, one picture, in this diagram, there is one normal thing, and there are other three things that are abnormal, that indicates the presence of disease. But this is the uh, normal fascicular muscle architecture. Okay, disease is at initial stage and there is no fascicular muscle alterations. No, there is a normal fascicular muscle alteration architecture, and you can see there are the slight variation of the myofibril sizes, and you can see there are not big differences, only slight changes. This is small, this is small, and this is large. And you can also see another. This is the one thing that is abnormally present. This is the second, and this is the third. In the second, this is the endometrial fibrosis. You can see this is the pink color. Let me draw it with the pink color. This is the pink color fibrosis is present over there. मैं यूनिवर्सिटी में बैठा हूँ तो पीछे शोर बहुत हो रहा है, तो जस्ट बेयर दैट नॉइस विद मी. This is the this is the fibrosis, endometrial fibrosis. This is normally present, and this is the basophilic regeneration of the cell. This is the basophilic regeneration of the cell. You can see here basophilic. This the left side of this diagram. This is the basophilic regeneration of the cells. New cells are being formed here, and you can in this picture you can see here that this brown demarcation around the myofibers shows the complete absence of the dystrophin. And in this diagram you can see here that this is the fibrosis and this is the endometrial fibrosis. You can see this is the pink area, and this pink area shows the endometrial fibrosis, and you can also see here the extensive variations in the myofiber sizes. This is a very small fibers, and this is a very large fiber, and this is also a large fiber. And what is this? What this white color indicates in this diagram? This white color is what is this white deposition? Of course, this is the fat replacement, fat infiltration. This is the fat infiltration. And in lab diagnosis, and during the first decade, muscle damage occurs, and it may lead to the increased creatine level in the blood. And as the disease progresses, the creatine level decreases because there is a muscle mass lost, and aldolase also increased. Aldolase enzyme is also increased in the blood. And now let's talk about the USMLE related concepts. And this piece of book, this piece of page is taken from the USMLE step 1. And in the muscular dystrophies, in Duchenne dystrophy, this is an X-linked recessive disorder, typically due to the frame shift deletion mutation, as we talk about, and truncated or absent dystrophin proteins are present. And if these truncated or absent proteins are dystrophin protein present, it may lead to the progressive myofiber damage, and weakness begins with the pelvic girdle and progresses spirally, as we talked about. What is this pseudo-dystrophy of the calf muscles due to the fibromyopathy replacement? As we talked earlier, that there is in the lower extremities hypertrophy. There is a hypertrophy of the distal extremities. You can see here. This is the distal. This is the calf pseudo hypertrophy. Calf pseudo hypertrophy. You can see this is the lower limb, distal lower limb, and this is here is the hypertrophy. Why there is a hypertrophy? Because usually patient stands up with the help of the uh, initially at the initial stage of disease, patient uses the distal ends of their lower extremities, and hypertrophy occurs here, and muscle wasting occurs here. Muscle wasting occurs. Here is the distal proximal areas of this lower limbs, proximal areas of the lower limb. So that's why with the extensive use of these lower extremities, lower distal ends of lower extremities, pseudo hypertrophy occurs. This is occurs in the calf muscles. Now, onset is before the 5-year of age. Dilated cardiomyopathy is the common cause of death, as we talked about. This is a waddling gait. And grower signs. What is this grower sign? This is the main concept that represents this disease. That shows that patient has this disease, might have this disease. And what this diagram shows, patient is trying to stand up with the help of the lower upper extremities, and this is patients uses the upper extremities to help stand up, and classically seen as the Duchenne muscular hypertrophy, but also seen as the other muscular hypertrophies, dystrophies, inflammation, myopathies, and like in the polymyositis. This sign also occurs, grower signs. And here pushing the legs, pushing on the leg to stand. The patient is pushing the leg to stand, and you can say the thigh atrophy occurs. Here you can see thighs are very thin. Hypertrophy occurs. This has also suffered the patient from the lordosis. And this Duchenne deleted dystrophin. Dystrophin gene is present in the X chromosome, as we have talked earlier. Is the largest protein coding gene. 79 इसमें एक्सोन थे, ठीक है, और 2.3 मिलियन इसमें बेस पेयर से. बेस पेयर डिस्ट्रोफिन हेल्प्स. It increases the chances of the spontaneous mutation. Dystrophin helps anchor muscle fibers, primarily in the skeletal muscle fibers and cardiac muscle. It connects the intracellular cytoskeleton actin to the transmembrane protein alpha and beta dystroglycan, which can connect to the extracellular matrix. Extracellular matrix में कौन सी प्रोटीन थी? लैमिन 2 प्रोटीन, उससे कनेक्ट करता है. Loss of dystrophin may cause the necrosis of the myocytes. Increase creatine kinase and aldolase enzymes. Genetic testing confirms the diagnosis. In the genetic testing, we confirm this test with the Western blot test, and or sometimes with the PCR test. These tests are used for the diagnosis, genetic testing confirmation. In Becker dystrophy, X-linked recessive disorder, typically due to the non-primitive deletion in the dystrophin gene, particularly functional instead of the truncated. As we have talked earlier, that functionally active proteins, dystrophin protein भी प्रोड्यूस हो रही होती हैं और ट्रंकेटेड भी होती हैं, ठीक है. मीन टू से कि कुछ हद तक सेल फंक्शंस नॉर्मल होते हैं. तो इससे आप बेकर डिस्ट्रॉफी, ठीक है, बेकर इज़ बेटर देन Duchenne hypertrophy dystrophy, less severe than the Duchenne. Onset in the adolescent or early adulthood, mean to say its onset occurs later in the life, and deletions can cause the both Duchenne or Becker muscular dystrophies. 1/3 of the cases have large deletions spanning one or more exons. Okay, this is from the Duchenne and Becker dystrophy. You can see here myofibers. As we have talked at fibrofatty replacement to the muscles. This is the fiber. This is the fiber around this, and here is the deposition of the fat. Fibrofatty changes occurs. Fibro means to say the fat has is replaced by the muscle fibers. This presentation shows the fibrofatty replacement.